Thank you. I'm not an American. I'm not born in Canada. I practice in Canada, live in Canada. So the Americans in the audience, my apology to represent your perspective. However, all my professional linkage are of the United States. I very seldom attend a Canadian meeting, so I play like an American cardiac surgeon. Our guidelines are not much different than yours when it comes to how to manage a patient with, was written once, rewritten in 2006. My problem with guidelines is that if you take the article, either in JACC or in circulation, there are close to 500 references to prepare the guidelines. 99% written by experts, very competent cardiologists, very competent surgeons. Those guys represent the United States? Hardly. Use Mayo Clinic outcomes from mitral valve repair to recommend mitral valve repair to all asymptomatic severe mitral regurgitation, disservice to American society. That's my view. Because the reality, if you go out in the field and look what's happening, it's a tragedy. I introduced an operation in 1988 that was modestly revolutionary for a very small proportion of patients with aortic root aneurysms. And of course, I first published in 1990, nobody believed. By 95, people started to do. By year 2000 became the standard treatment, and they had to change the guidelines again, because Dr. David has an operation now. They even called the operation David. They worked very well in his hands, but they hadn't been reproduced yet. So this is not a joke. This is a true story. Last Tuesday, I was in the operating room. My secretary was looking for me because this lawyer was chasing me day and night. Because a 19-year-old Marfan, asymptomatic woman, never in her life had a symptom. She did not know had a Marfan syndrome. But she decided to have a premarital physical examination. And the GP said, you know, you look like a Marfan's. Small town USA, sent to the local cardiologist. Cardiology the neck of a third quality, third rate. And the aortic root was 42 millimeter. So he said, you better see our local surgeon. The local surgeon told her, you know, if you're going to get pregnant, the guidelines said you have to have this root repaired. She said, well, that's why I'm getting married. I want to have kids. So he replaced her aortic valve. She had no AI, a 42 millimeter aortic root. She left the operating room, severe aortic insufficiency, shut down her kidneys, went in dialysis. The prosthesis became infected. The guy took her back to the operating room, then did a homograft on her, developed a VSD, heart block. The homograft dehisced, went to a large center in the United States, had a bento, a pacemaker, and after 11 months in hospital and $900,000 in healthcare bill, she survived. Guidelines are not to tell a surgeon how to behave. That's, I think it's dangerous, to be quite honest. I have an endless number of cases like this. Tragedy. Don't tell a young surgeon to operate a 19-year-old. He was asked by the defense lawyer, who can defend you on this? Who's Tyrone David? Because he put in the operative note, Tyrone David operation. So the lawyer came after me to defend him. So I asked, how many times has he done his operation? Oh, he never done one, but he saw you operating. Oh, so he flew to Toronto, he saw me doing an operation, flew back home and did the operation. I have been accused to kill more people than anybody else in my area. Not because I kill personally, but because what I showed my friends what I can do, they try to do the same. I mean, I have a lot of gray hair. This morning I talked about 10,000 hours to develop an expertise in any area, quoting the psychologist of Erickson. I think aortic insufficiency, we are far, far away to operate in asymptomatic patients yet. The day hasn't arrived yet. I think you should operate in aortic insufficiency the way the guidelines read, the American guidelines read, which is very similar to yours. It's not much different. If the patient's symptomatic, of course you're going to help the patient if you can withstand an operation. If the patient is asymptomatic, but has sign of ventricular dysfunction, or if you put on an exercise, and instead of the ejection fraction go up, I don't know if yours contain this data, during exercise the ejection fraction goes down, there are 2 or 3 papers showing as a bad marker. So don't wait until the ejection fraction goes down. Go and do something about the aortic valve. And finally, at the time of other surgery, if you only operate room anyhow, and the aortic valve is leaking more than mildly, replace the aortic valve. I think it's reasonable to operate in asymptomatic patients that have very large heart, and it's identical to yours again. I think this might be a bit too large, 75 systolic. If you do, I very early on in my career put a paper on 10 years follow-up of pure aortic insufficiency, and people did end systolic that are more than 50 did not recover. Half of them did not recover. It's published. And this was published in the 80s. And it took many years to see improvement. It takes up to 10 years to see full restoration of function of the aortic valve replacement in large ventricle, but not all of them. There's a degree of unpredictability in patients that you continue following after such a large ventricle. My personal cutoff is a bit more conservative. Diastolic I don't care as much, particularly ejection fraction is still very high, but diastolic more than 50 is a bit intimidating. Perhaps the index would be a better way to measure for the just for, and our paper did not do that back in the 80s. You should consider also aortic valve replacement in patients with aortic ascending aorta disease, and that's the controversial area that was discussed before. Should we be more aggressive in this patient? Because those patients can have a satisfactory long-term result if we operate them sooner, primarily because the disease is the ascending aorta or aortic root. And all this is not different than yours, really. I'm repeating what was said before. This is a controversial one, and the problem is when the aortic valve is repairable. You heard the Gebrin in the past 2 or 3 days, and Alec mentioned Schaefer's, and the list becomes really fingers of single hand. Gebrin in Brussels, Schaefer's Hamburg, Tyrone Dave in Toronto, and then I'm looking for somebody else to put a 4 and 5 that repair the aortic valve. The aortic valve repair is not common, and it's not simple either. Aortic root repair is a bit more reproducible, and perhaps we should be more aggressive in those patients to save their aortic valve, because there are data now that the long-term result is not bad. And luckily, in this part of the world in mine, dilatation of the aortic root is the principal cause of aortic insufficiency. A pure aortic insufficiency without dilatation of the aortic canal is almost unheard of in Canada, England, I bet to say. Perhaps an immigrant has rheumatic heart disease, but in countries where you don't see rheumatic heart disease, bicuspid aortic valve is number 1. Number 2 is primary dilatation of the aortic annulus or sinotubular junction. That's why imaging of the aortic root in this patient is very important. And I continue relying very heavily on transesophageal echocardiogram before I take a patient on for aortic valve repair. Of course, you need a complete imaging to see if the rest of the aorta needs. I think it's very important to distinguish anatomically what you're talking about is root or ascending aorta. Dilatation of the ascending aorta is far more benign in natural history than dilatation of the aortic root. A 50-millimeter aortic root is a pretty serious business if you have abnormal fibrillin or any genetic abnormality for any familial aneurysm. It's not the same for bicuspid aortic valve. It's not the same of 55-millimeter ascending aorta. So the patient might have AI, but why is the AI present? Is the AI present because of a disease of the aortic root? This is the cusps, the annulus, or the ascending aorta. There are basically three groups of patients. One is the, I'm sorry, I goofed here. One is the patient, is the elder patient. The patient was a 6 or 7-year-old, severe aortic insufficiency. And the primary problem is dilatation, the ascending aorta. And the aortic insufficiency is resulting from dilatation sinus to blood junction. If this patient is asymptomatic or not, he's going to come for an operation primarily because the aorta is a bit larger. It may not fulfill the guideline. This aortic insufficiency is severe. The aorta is only 45. But it is worthwhile to operate in asymptomatic because the operation is simple and reproducible. Only by adjusting sinus to blood junction, you can fix the aortic insufficiency. Just about any surgeon with a good sonographer can do in the operating room. Things become more complicated when it's genetic-mediated aneurysms. When the primary problem is dilatation, the sinus valsalva, the problem starts in the sinus valsalva and propagates both ways. It goes down to the annulus and goes upward into the sinus to blood junction in the aorta. Here, some experience on aortic surgery is necessary. And again, you need a sonographer to help you, to guide you through these types of aortic valve sparing operation. And finally, the most complex one is this one here. The one where the primary problem is inside the heart, is the fibrous tissue of the outflow tract that opens up, and God knows why. Genetically mediated again. And the patient develops severe aortic insufficiency, and they have a massive annulus, 35-millimeter annulus, beautiful cusps. But then only the surgeon can operate inside the heart, do an operation in the annulus. And that surgeon has to know anatomy of the aortic valve inside and out to be able to reduce to a size that renders the aortic valve competent. Not a very easily reproducible operation. Very simple. Here depends on the center where you are. And this one here really is domain of very few people because it's not that common. More guidelines for surgeons too about the ascending aorta. And I think a chronic ascending aortic aneurysm is reasonable to wait until 55, unless you have family history of dissecting aneurysm or a genetic abnormality, proven the abnormal fibrillin or some other gene-associated dilatation. Of course, if they are mediated and they have history, be more aggressive. And if you increase more than 5 millimeters in a year, that's a bad sign. And finally, if you're operating, if you're in a patient anyhow, doing whatever operation, and the aorta is more than 45 millimeter, the natural history shows that except if the patient is 80, anybody else younger than 80, eventually the aneurysm dilates and might develop aortic insufficiency, dissect, or rupture, and it makes sense to operate. Prevention of dissection cannot be based on size. Your registry in Europe show that dissection happens equally common in small aorta than in large aorta. Largely age plot against this here make more sense. The older patients usually dissect the normal aorta. Younger patient, the genetically mediated disorder require a large aorta. Marfans can attain size of 10 centimeter before they dissect or rupture. Ascending aorta can be a bit more conservative if it's ascending aorta alone, and 55 is a reasonable cutoff. Natural history must be placed against surgery, and this stuff bothered me. This is a published paper from the SGS database. It's old, it's 10-year-old. I looked last year, it's no different. The operation mortality in the United States to replace an ascending aorta is 10%. If you replace acutely, 24%. If you do an aortic root replacement, 9.5%, so a bento. So this is reality, not 0.5% that I published, not the has 0% that Schaefer's published, or 0.7% that Gebrini Alcuri published. To use those numbers is totally unrealistic to dictate or to write guidelines. This is real world. If your mortality for bento is 10%, you should only operate on a patient in whom next year the natural history is worse than 10%. If the chance of rupture and death is 1% and you kill 10, well, why guidelines? Common sense is more important. Thank you.